Good morning, everyone. Today, I'm going to critically analyze the BLISS lupus nephritis trial, which is Belimumab in lupus nephritis. So this is a 2-year randomized control trial of Belimumab in lupus nephritis, and it was published in New England Journal of Medicine in September 2020. So I'm analyzing this research with regard to the critical appraisal study program checklist. This is a critical appraisal study program checklist, and it has 3 main sections, and under each section there are several components as well. So the 3 main sections in the critical appraisal study program are the results of the trial valid, what are the results, and will the results help locally? So when we consider are the results of the trial valid, there are several components under this. Did the trial address a clearly focused issue? Was the assignment of patients to treatment randomized? Were all of the patients who entered the trial properly accounted for at its conclusion? Were patients, health workers, and study personnel blind to treatment? Were the groups similar at the start of the trial? And aside from experimental intervention, were the groups treated equally? So first we look whether did the trial address a clearly focused issue. So for this, we need to analyze the relevant background information, adequacy of the literature survey, rationale of the research, and just whether the justification is adequate or not. The lupus nephritis occurs in about 25 to 60% of patients with SLE, and it is the most common severe manifestation of SLE and is a major cause of illness and death. Despite aggressive therapy, only a very low percentage achieve remission and 10 to 30% progress to end-stage kidney disease. In lupus nephritis, there is heightened production of B-cell activating factor within the kidney and increased level of serum B-cell activating factor in patients with lupus nephritis. So neutralizing B-cell activating factor with a subsequent downregulation of B-cell function decreases in autoantibody production and inhibition of tertiary lymphoid structure formation in the kidney is a compelling therapeutic approach to lupus nephritis. Belimumab is a recombinant human monoclonal antibody. It inhibits the binding of soluble B lymphocyte stimulator, a B-cell survival factor, to its receptor on B cells. And Belimumab does not bind to B cell directly, but by binding to Belimumab lymphocyte stimulator. By that, it inhibits the survival of B cells, including autoreactive B cells, and reduces the differentiation of B cells into immunoglobulin-producing plasma cells. So Belimumab was approved in 2011 for use in patients with active systemic lupus erythematosus, but not in those with severe central nervous system and renal involvement. So in BLISS 52 and BLISS 76 studies, it was assessed. However, in these studies, acute severe lupus nephritis were excluded from the above studies. And so there's no data on efficacy of Belimumab in lupus nephritis. Therefore, the phase 3 post-hoc analysis involving patients in BLISS 52 and BLISS 76 who had proteinuria at baseline showed decrease in proteinuria and a lower incidence of renal flares in patients who received Belimumab. And the current standard of care treatment for lupus nephritis consists of corticosteroids and immunosuppressants. The systemic review of recent trials in lupus nephritis concluded that mycophenolate mofetil is as effective as cyclophosphamide in inducing disease remission. And the post-hoc analysis, however, in BLISS 52-76 demonstrated that there was decrease in proteinuria. Therefore, the understanding whether the Belimumab plus standard of care can reduce the disease activity in subjects with active lupus nephritis is imperative. So all previous studies involving patients with lupus nephritis had 6 or 12-month period endpoints. And most studies involving patients with lupus nephritis have also excluded those who were receiving cyclophosphamide. So the aims and objectives of this study are to evaluate the efficacy of Belimumab in combination with standard of care in adult subjects with lupus nephritis class 3, 4 or 5, and to assess the safety and tolerability of Belimumab plus standard of care versus placebo plus standard of care in adult subjects with lupus nephritis class 3, 4 and 5. So did the trial address a clearly focused issue? Yes, as I explained before, it addressed a clearly focused issue. And the other components I would like to describe while I'm describing the methodology. It's a phase 3 multinational, multi-center randomized double-blinded placebo-controlled trial, which was done in 107 sites in 21 countries. So Asia, US, and Europe were included. In Asia, China, Hong Kong, Korea, Philippines, and Taiwan and Thailand were included in the study. So these were the inclusion and the exclusion criteria. So the inclusion criteria were at least patients, the subject should be 18 years of age and autoantibody positive with ANA plus or minus dsDNA and fulfilling the ACR criteria, and urine protein creatinine ratio of 1 or more, and biopsy proven lupus nephritis of class 3 or 4 with or without coexisting class 5 or pure class 5 lupus nephritis within 6 months, and biopsy specimen showing active lupus nephritis or active plus chronic lupus nephritis. The exclusion criteria were dialysis within 1 year and eGFR less than 30 milliliters per meter per square meter, and previous failure of both cyclophosphamide or mycophenolate mofetil, and receipt of cyclophosphamide induction therapy within 3 months before the trial, and receipt of B-cell targeted therapy within 1 year before the randomization. So patients were randomly assigned into 1-to-1 ratio using an interactive web response system at day 1. And the randomization was stratified according to induction regime, whether it's cyclophosphamide and or mycophenolate mofetil, and the race group, whether it's black or non-black. So in this study, 448 subjects were included. Out of that, 224 received Belimumab plus standard of care, and the other 224 received Belimumab plus standard of care. And out of this, in each group, mycophenolate mofetil was received by 164 subjects, and cyclophosphamide received by only 59 subjects. So this choice of induction treatment was not randomly assigned, but it was selected by the treating physician, and therefore this choice may be susceptible to unknown influences. And it was based on the ALMS and urolupus nephritis trials. And the trial agents were prepared by the pharmacists who were aware of the trial group assignment, and patients and staff were unaware of the trial group assignments, although the independent monitors were aware of these assignments. So apart from Belimumab as placebo, the standard of care included induction therapy with IV cyclophosphamide, which is 500 milligram every 2 weeks for 6 infusions, or mycophenolate mofetil 3 grams per day. And the maintenance therapy for the cyclophosphamide therapy, maintenance was achieved with azathioprine with a dose of 2 milligram per kg until the trial ended. And this azathioprine was initiated 2 weeks after the last dose of cyclophosphamide. For mycophenolate mofetil, 1 to 3 grams per day mycophenolate mofetil was administered until the end of the trial, and after 6 months, the doses could be reduced to 1 gram per day. Apart from these, patients were able to receive high doses of glucocorticoids, IV methylprednisolone, and followed by oral prednisolone, and receipt of AC inhibitors or ARB blockers, as well as HCQ. In addition to this, Belimumab or placebo was given at day 1, day 15, day 29, and every 28 days until week 100. And then monitoring was conducted with clinical evaluation, disease activity assessment, at each visit, and then laboratory assessment with urine protein creatinine ratio, eGFR. So this is the study calendar. So it shows that it has been assessed clinically as well as disease activity indexes and also laboratory criterion as well during each visit and 28 days. Upon completion of 104 weeks, subjects also enter for a 6-month open label extension. In the open label extension, all the subjects will receive Belimumab 10 mg per kilogram every 28 days until week 24 with a final evaluation at week 28. At the end of 6-month open label extension period, subjects who wish to continue treatment may do so by prescribing commercially available Belimumab. So monitoring of safety. There was an independent data monitoring committee reviewed unblinded safety data on an ongoing basis until week 104. This independent data monitoring committee includes physicians with expertise in infectious diseases, rheumatologists, nephrologists, and a statistician, none of whom are affiliated with the sponsor. So the adverse event that they look for are hypersensitivity and anaphylactic reaction, serious infection, laboratory abnormalities, opportunistic infection, malignancies, death, and serious psychiatric events. So coming back to our checklist, was the assignment of patient treatment randomized? Yes, it was. And were all of the patients who entered the trial properly accounted for at its conclusion? Yes. And patients, healthcare workers, and study personnel blind to the treatment? Yes, it was. So let's look whether the groups are similar at the end of the trial, at the start of the trial. So for this, we will look at the demographic data. So this demographic data shows that the groups Belimumab and the placebo groups demographic characteristic wise, it was more or less similar. So there were females about nearly the same amount, and the age group also same, and race as well as geographic region and also the other factors were more or less similar in Belimumab as well as placebo groups receiving placebo. Then we look at whether aside from the experimental intervention, were the groups treated equally. So apart from the experiment, that is either to receive Belimumab or placebo, the groups were received standard induction therapy with cyclophosphamide MMF and maintenance therapy with azathioprine MMF, and apart from that, glucocorticoids, ACE inhibitors, ARBs, and HCQ. So it has also addressed the groups were treated equally. So now we'll move on to the next section in this critical appraisal study program 2. What are the results of the study? So for this, we want to look at how large was the treatment effect, what outcomes were measured, is primary outcome clearly specified, what results were found for each outcome, how precise was the estimate of the treatment effect, what are the confidence limits, and were they statistically significant. So first we look at the primary outcome. So the primary efficacy endpoint is primary efficacy renal response at week 104. It is as follows. A response is defined by a response at week 100 visit confirmed by a repeat measurement at week 104 visits. So the estimated eGFR should be no more than 20% below the pre-flare value or more than 60 milliliters per minute per square meter, and urine protein creatinine ratio of less than 0.7, and no receipt of prohibited therapy or rescue therapy resulting in treatment's failure. And the major secondary endpoints were complete renal response at week 104, that is a ratio of UPCR less than 0.5, and eGFR that is no worse than 10% below the pre-flare value, and more than 90 milliliters per minute per square meter. And the primary efficacy renal response at 52 weeks, and time to renal related event or death, and ordinal renal response. So what is the definition of treatment failure? If participants violated the glucocorticoid rules or received additional immunosuppressive agents except topical agents beyond the induction and maintenance regime, it is considered as treatment failure. And also, if the AC inhibitors or ARBs or anti-malaria drugs were started after week 24, it is also considered as a treatment failure. And if the standard therapy was cyclophosphamide, azathioprine, or MMF exceeded the permitted doses, it was also considered as a treatment failure. So what is this glucocorticoid rule? So glucocorticoid, according to the trial, glucocorticoid should be tapered and it should be about 10 milligram or less per day by week 24 and not to exceed this dose through week 104. And no glucocorticoid rescue treatment were allowed between weeks 75 and 104. So according to this, it has its primary outcome was clearly specified. And what results were found in each outcome? For this, we'll look at how this study was analyzed. So to have a power of 80%, at least about 400 participants should be enrolled in the study. And to have a power of 85%, about 464 subjects should be enrolled. So because of this, between 400 to 464 lupus nephritis subjects will be randomized with a target of at least 200 and up to approximately 232 subjects in each treatment group. So analysis of data. Efficacy and endpoints were analyzed in the modified intention to treat population. So modified intention to treat population means that patients after randomization who received at least one dose of Belimumab or placebo. And the primary efficacy renal response at week 104 was compared between Belimumab and placebo using logistic regression controlling for induction regime. And the secondary endpoints, complete renal response at 104 weeks, also, and primary efficacy renal response at week 52 was also analyzed using logistic regression control. And this time to death or renal-related event will be compared between Belimumab versus placebo using Cox proportional hazard model controlling for induction regime. The null hypothesis of this trial is there is no difference in renal response rates for Belimumab plus standard of care versus placebo plus standard of care at week 104 of the double-blind treatment period. So these were the primary and major secondary efficacy endpoints in modified intention to treat population. The primary endpoint or the primary efficacy renal response at week 104 in patients who were treated with Belimumab plus standard of care was 43%, whereas in the placebo plus standard of care it was 32%, with an odds ratio of 1.6 at the confidence interval 1 to 2.3, with a p-value of 0.03, which was statistically significant. Considering the major secondary endpoints, the complete renal response at week 104 was 67 subjects, with its 30%. And when patients who were treated with placebo plus standard of care, it was 20%, with an odds ratio of 1.7, and with a confidence interval of 1.1 to 2.7, and the p-value was 0.02, which was also statistically significant. And the primary efficacy renal response at 52 was also statistically significant with a p-value of 0.02. So when considering the primary endpoint and the complete renal response at week 104, you can see that the percentage in the primary efficacy renal response is about 43%, whereas the complete renal response at 104 weeks was 30%. So this is due to because in patients with low baseline serum creatinine levels, even a small absolute increase in result in relatively large, even a small percentage of change in serum creatinine cause a relatively large percentage changes. So such patients may thus be at risk of inappropriate classification as not having a response, because it was considered if the eGFR is less than 10%. That was what was expected in complete renal response. eGFR should should not be less than 10% compared to the pre-flare value. And who were these non-responders? They are subjects who withdraw from the trial and treatment failure, and even the discontinuation of Belimumab or placebo were imputed as non-responders. Patients who were withdrawn and treatment failure as well as discontinuation of Belimumab. So this is a renal response over time. In considering Belimumab and placebo, renal response over time was high in Belimumab group compared to the placebo plus standard of care in primary efficacy renal response. And complete renal response over time was also high in Belimumab group compared to the placebo group. And this was probability of renal related event or death. So the renal related event or death was low in Belimumab group compared to the placebo plus standard of care with a hazard ratio of 0.51. So we'll move on to the subgroup analysis. Both the mycophenolate mofetil and cyclophosphamide azathioprine subgroups, more patients who received Belimumab plus standard of care had a primary efficacy renal response than patients in placebo group plus standard of care. However, this odds ratio in the MMF subgroup is about 1.6 with a 95 confidence interval of 1 to 2.5. But the odds ratio in the cyclophosphamide group is 1.5 and this 95 confidence interval was 0.7 to 3.5. And the most of the treatment effect was seen in patients who received mycophenolate mofetil. And there was no benefit was present in subgroup of patients who received cyclophosphamide azathioprine because the confidence interval encompasses 1. So the overall response was driven by the result in large mycophenolate mofetil group, which is somewhat of a limitation in this study. And the choice of induction treatment was also not randomly assigned but selected by the treating physician. And therefore, this choice was susceptible to unknown influences. And there were some disparities in the baseline characteristic between MMF and cyclophosphamide groups. They are higher level of urinary proteins, lower eGFR, low complement concentrations, and longer disease duration. So therefore, patients with more severe nephritis may have been in the cyclophosphamide group, which would have led to the relatively poor response in treatment with cyclophosphamide subgroup compared to mycophenolate mofetil. And the other thing was race-wise, Black patients with lupus nephritis are more likely to have a worse prognosis than those in other racial groups. However, in this trial, the primary and secondary outcome endpoints in Black patients were similar to the overall trial population. So due to the low enrollment of Black patients to this trial, this community would have been properly not representing the subgroup analysis. So we'll move on to how, through this we can say that the confidence limits and these were statistically significant. So we have looked into the second section in this critical appraisal, the results of the study. So now we'll move on to will the results help locally. Are the patients covered by trial are similar enough to patients locally seen? Were all clinical outcomes considered, and are the benefits worth harm and the cost? So will the results help locally? The highest number of patients enrolled in the study are Asian. However, Sri Lanka or India was not included in the study. And the demographic data from Sri Lankan study done by Professor Kalapati and colleagues showed that the following demographic features which has only some characteristics to the study population, such as the mean age of SLE patients in this trial also 32 years, and lupus nephritis also the mean age is similar. However, there were limitations in this trial. The trial does not provide information on the efficacy of Belimumab as a sole primary treatment for lupus nephritis. It does not provide information on whether Belimumab has a role in treating patients in whom induction therapy fails or those with relapse. And treatment effect was seen in patients who had received mycophenolate mofetil, which had a large number of participants. And no benefit was present in the subgroup of patients who received cyclophosphamide. And choice of induction treatment also was not randomly assigned, but selected by the treating physician. And a low enrollment of Black patients who are an important subjects of patients as the disease is more severe in them. And only 2 induction and maintenance regimes were permitted as background therapy, although there are additional therapies for lupus nephritis, such as calcineurin inhibitors, are currently used in practice. And the cost and the availability is also a limitation. And also there is change in the primary endpoint during the trial. So the primary trial endpoint was changed in 2017, which was 5 years after the trial began. And the results with respect to the original primary endpoint, which categorized responses as complete, partial, or no response according to the level of proteinuria, the calculated GFR from 24-hour urine collection, and microscopic examination of urinary sediments. However, this revised primary endpoint, or the primary efficacy renal response, which is unique to this trial, did away with the partial response category, and it omitted the urinary sediment component used as serum, and also it used serum creatinine level rather than 24-hour collection, and also it loosened the proteinuria criterion as well. The change in the primary endpoint may be acceptable if critical new information surfaces that affects the usefulness of the original endpoint, but it is important to know whether the decision to change the endpoint was independent of any data collected before the change. So, will the results help locally? So, are the patients covered by the trial are similar enough to this patient's locally seen? This is only to a certain extent, and we can't really say that. And were all patient outcomes were considered? That is also to a certain extent only. And are the benefits worth harm and the cost? And it is yet to be decided. Sponsorship and funding. The sponsor GlaxoSmith, which contributed to the design of the trial, the collection, analysis, and the interpretation of the data, and the decision to submit the manuscript for publication, and supported the authors in the development of the manuscript. And medical writing support was also funded by the sponsor. Authors' conflicts of interest. All authors' reports receiving advisory board fees, travel support grants from various pharmaceutical companies, including the sponsor. So in summary, this critical analysis study program has 3 main sections. So most of the sections were covered, and however, whether this trial could be applied locally is still questionable. And this demographic data comparing the study and the local population also we can't exactly say, and the cost benefit wise also we cannot exactly say.
I just want to clarify. You have given the patients while on cyclophosphamide or immunotherapy. Is it a separate group?
While on cyclophosphamide and immunotherapy, apart from the standard of care, Belimumab and placebo was given. So it was not tested as the primary treatment. Belimumab was not tested as a primary treatment, but while the patients are on cyclophosphamide and mycophenolate.
Side effects more common and right on video. Side effects in combination.
Actually, it was not reported comparing the placebo group. In the Belimumab group, side effects were not was not reported as common. It was more or less same, and renal-related events were less in Belimumab group compared to placebo group, and other events were more or less the same.
Any other questions? Thank you very much, Charmi. Our next speaker for today's program from the College of Rehabilitation is Dr. Jayathri Jagoda, consultant rheumatologist from Colombo. She'll be talking about the chronic bone pain.
Good afternoon to you, and thank you, Dr. Vidas, for the introduction. So I had the challenging task of presenting something from LRH to an adult forum. So I was thinking of what to talk. I got a call from an eminent orthopedic surgeon from the adult world, telling that he had a very interesting patient who has gone to many doctors and even to Singapore, having a lower leg pain, which is difficult to diagnose. And a group of doctors are working on this. Could I help? So then I told, of course, they can come to LRH, but then they came to private sector with a whole lot of MRIs and years of investigations. I went berserk. I told, I can't do it here. Please come to my clinic, and with all the investigations, and my senior registrar and myself a week to process through the investigations, and then we arranged a discussion. So this is that patient's story. This 12-year-old girl had recurrent episodes of left ankle joint. You can't say that it is really ankle, it's a little above ankle, left lower leg pain and swelling, and left hip pain since 8 years of age. Started in 2016, and no other joint involvement at that time. There's no history suggestive of inflammatory arthritis, no other systemic features like fever, malaise. In her first episode in 2016, the investigations done back then showed an ESR of 68 and CRP 12.7, and all other full blood count, phosphate, ferritin, blood phosphate is normal. Immune markers like rheumatoid factor, NTCCPA, double standard negative. Ultrasound of left ankle joint shown some soft tissue swelling inferior and medial to the left lateral malleolus. She was treated to be having transient synovitis with oral antibiotics and NSAIDs. And then the problem subsided, went quiescent, and there was a second episode in the next year. Again, with this time, the girl had some swelling. ESR was 20, but there was some periarticular soft tissue swelling, and she showed some lower limb swelling as well. She was treated again as mechanical pains. She was given insoles, and she settled with strengthening exercises. So there was a third episode in 2018. Again, left ankle pain and spine pain this time, and buttock pain. Again, couldn't categorize this as inflammatory. And then they were well defined, and they went to Singapore this time. And if you can see, that was the X-ray taken at that time with an ESR of 30, and CRP was 2.2, not very significant. And the X-ray now showed a loosened area with a sclerotic rim to distal left tibia. Then an MRI left ankle joint was done, and there was a well-defined area of signal change. The distal tibia tibial metaphysis, suggesting of significant edema, which was contrasted here, and clearly see that lesion. So MRI hips and pelvis at that time has also shown mild edema and enhancement at lower halves of bilateral sacroiliac joints. That was interpreted as early sacroiliitis or stress changes. Mild edema at neck and intertrochanteric regions of both femur. And they have done a bone scan to see whether other areas of the spine is involved. So there's moderately increased trace activity in distal tibia query infection. Mild increase in trace uptake in bilateral sacroiliac joints. That was the interpretation of Singaporean radiologists. They have done left distal tibial core biopsy, which has shown edematous fibrous chroma and sprinkled inflammatory cells. There was no active inflammation or dead bone or granuloma or malignancy. So then with this loosened area with bone edema and sclerosing bone around it, they have done investigations to screen for Pox, TB, bacteria, and fungi all have become negative. Again, the full blood count and the general investigations are all negative. CRP was normal. This time they have found a positive ANA with normal C3 and C4 level. One of the reasons that they wanted me to look into this was this positive ANA. The double stranded DNA, ENA panel all have been done and that was negative. They have at this stage treated as undifferentiated JIA. They have thought of undifferentiated JIA with the non-bacterial osteitis and bilateral sacroiliitis and non-specific narrow edema at the neck of the femur. With the positive ANA, they have started to treat this child as JIA. Then the child was prescribed methotrexate, which she didn't like. She got nauseated, and the steroids, at some stages, steroids were also given, and then she deformed. And then she was silent for a while, for 2 years. And then this time, this year, April, things came up again. This time, again, she got bone pain, and as you can appreciate, the lesion in the bone has there's gross expansion of the bone now and advancing radiological changes. So ESR was 39 now. CRP just remains at 4.3. And this is the X-ray you are seeing with loosened area and the distal tibia and significant expansion also. And MRI left tibia was done, MRI pelvis, and both hips are normal. ANA again repeated more than 1 in 100. This time in Sri Lanka, a true cut biopsy was arranged again. In that, it came as appearance suggestive of chronic osteomyelitis. So with this, now the people were really confused. Now this is coming in episodes, 3 episodes, and every time the biopsy done earlier, and this time also didn't last. The first time the biopsy was done, they were really scared of malignancy, and chronic osteomyelitis were considered, but nothing, no solid diagnosis was available. And now the child was followed up with the orthopedic surgeons, and they were really confused. And there was this ANA being positive 2 times. This is my first case. And then there was this second patient, a 13-year-old, who was actually presented to me from our orthopedic colleague, because when I get such a patient, I always go and talk to him. We are in very good working relationships. This child he was following up. So he thought that this problem is progressing. So he presented this child to me. This child has had arm pain with investigated for right elbow and forearm pain. Elbow and forearm. The first episode being in 2017. There was no history of fever or joint pains, no variations to suggest inflammation, and this girl's ESR was 84 and CRP was 72. So now this child had very high ESR and CRP. And X-ray of the elbow showed multiple lytic lesions with perotic rim. And ultrasound scan was done and queried acute osteomyelitis and malignant bone tumor. This is 2017 at the first presentation. Very justly thought of malignancy. So then MRI of right elbow and forearm was done. Now, their conclusion was appearances of a malignant bone lesion involving right proximal radius. Considering the age, they have suspected Elisa. These are her X-rays and MRI findings. 5 dramatic scary-looking lesions. Despite the parasitic, the biopsy was done at that stage. Open biopsy was done. Diffuse reactive wound formation, no evidence of malignancy, no evidence of acute. In contrast to the most dramatic changes that are seen in the X-ray and the MRI. Again, TB was suspected, MANT was negative, managed as acute osteomyelitis. And the pain went down, but she has had progressive changes in the bone. So there was this second episode after 3 years in 2020 with X-ray showing again multiple loosened areas with some tissue. The disease is going on, and again it was giving trouble. For 2 years, 3 years, it was present. The second MRI done again showed infective or inflammatory lesions, as you can see there, in the proximal radius. There's no abscess formation and poor response to the treatment that was given. So biopsy was repeated. Forearm is scarred with, multiple biopsies. Repeated biopsy again showed chronic osteomyelitis, no evidence of malignancy or TB. So this 3 years, the child has been having expanding bone lesion, but there's no evidence of malignancy. So I encountered another patient. This was also quite recent. This is a 10-year-old girl. Who has actually presented to one of our colleagues, a junior colleague to me, first episode in June 2020 with right foot pain, not a rheumatologist, but I think a GP or another specialist has seen with this first foot pain. With that foot pain, he has taken an X-ray of the foot. So the pain went down. The pain has resolved after 1 month with analgesics and anesthesias. And in August again, is after 2 months, again presented with right knee pain below the joint line to one of the rheumatologists. So who thought this was a 10-year-old girl, I shouldn't be looking after this girl, and referred to me, who has not seen the ankle X-ray. There were no, in the history, there were no features of inflammatory pain, and there was no swelling in the joint, but she complains. So her ESR was 38 and CRP was 22. So this is her X-rays. Again, with a few days history, this was done in April with the first episode, which shows dramatic bone expansion and periosteal reaction in the second metatarsal bone. And there's another lytic lesion in the base of the fifth metatarsal. So we got this child down to LRH and did MRI. So it showed again knee joint because that X-ray was previously taken. So the MRI was done in the knee to show the well-defined area of signal changes in proximal to the exit metaphysical involvement. North plate and significant edema which was enhanced with contrast. So now all these three cases, one case the ESR and CRP had been fluctuating with dramatic bone changes, and second case it was very high at the initial stage, and the initial two cases have gone on for years. Now for my first patient, we arranged a multidisciplinary meeting with the radiologist and the orthopedic surgeon. We all met one day to discuss about the patient who went to Singapore and came back because there was so much of confusion. So when we discussed the X-rays, so our radiologist had doubts about the sacroiliitis that the orthopedic, the radiologist who have interpreted in Singapore. So when the orthopedic surgeon showed the X-ray, he said, he just told the diagnosis. He said no further biopsies needed. This is such an illness. So what are the differential diagnoses? So as you can see, when the patients first present with dramatic expansion and lytic lesions and so on, it's quite naturally we have to consider the most common and dangerous differentials. So infective osteomyelitis, malignancy. So of course the infective causes, osteomyelitis might have focus around the knee, and there might be fever and so on. So malignancy should be always considered, and avascular necrosis and chronic arthritis, because JIE, this first girl has presented with ankle pain, and the second one came with knee, third one came with knee pain. So all these are involved in the differential diagnosis, and they can have quite severe pain. So amplified pain syndromes and hypophosphatasia, chronic and the last chronic multifocal osteomyelitis. But it should not be the first differential diagnosis you should be looking at, because there can be so many dangerous things that could have happened. So there usually is a delay in diagnosing. Even in the most centers of the world, 2 to 3 years might pass before somebody comes to the diagnosis, because there is so much of confusion. But seeing a lot of cases, our orthopedic surgeon is at a glance is able to tell this, and number of times he has refused my pleas to do a biopsy, and he's very confidently telling, you don't need a biopsy. This is this. So it is. So I thought it's worth sharing this. It's kind of like a spot thing. Sharing this picture with the adult world also, because these kids are going to grow and they are going to come into adult world, and they are episodic, and my adult colleagues might see look at encounter acute exacerbations of this thing with dramatic bony changes which might strike you. So this girl in cases, infective osteomyelitis and malignancy was excluded, and avascular necrosis, secondary causes were excluded, and chronic arthritis, no features, and amplified pain syndromes, no allodynia, discoloration, or temperature differences. So chronic recurrent multifocal osteomyelitis diagnosis was arrived at. the important thing is it's a diagnosis of exclusion again, a clinical and a combination of all the picture, the time that has evolved. Our third patient, we are still investigating. I mean, we are doing, sometimes we do whole body MRIs. So to see whether there are other sites involved. The child might not have pain, but there might be other silent sites which we will pick up. So it could always be a diagnosis of exclusion. So coming to our diagnosis, chronic recurrent multifocal osteoarthritis. It is also called CNO, which is chronic stands for chronic non-bacterial osteomyelitis. It's a process of chronic sterile inflammatory disorder in children that primarily affects the bones and can cause bone destruction if untreated. So this, my first girl, in fact, has a very wobbly ankle. Now she walks with a lot of, insoles and things. So with time, it can be damaging. So we need to diagnose. This is a rare disease. I don't know how rare, but I, of course, have encountered, I know nothing much about this. I knew only the name when I went to LRH. I went to LRH with a big worry in my head because I thought I'm from an adult world, basically going into children's world. There might be a lot of things that I don't know. I only knew the name. So, but after I went, I think I have seen about 10 cases. So I don't know how rare this is. We are increasingly seeing these cases. In fact, I saw one patient with Palitha, if Palitha remembers, when these changes can happen in the vertebrae. Occur in the vertebrae, which makes it very difficult to get a biopsy. Even touching that brittle bone for biopsies, orthopedic surgeons may not venture to do. So it's a difficult thing. So it's a rare disease. So CNO is likely underdiagnosed and underinterpreted due to lack of awareness. So I myself was not aware. So this much to this level. So I thought others might not be aware also. So an absence of validated diagnostic criteria. So the world is still struggling to make compose diagnostic criteria for this. I will discuss later. There are few in the pipeline, but there's no one strong set of criteria to diagnose. So can affect children all ages with a peak of onset between 7 and 12 years. But the literature says that if a child presents, very early in life, like infancy, months, under 2 years, you have to strongly consider other differential diagnosis as well. So very young age, it's not very likely. So there's a female preponderance. Many of my patients, I think out of about 10 patients, I got, I think I got only one male patient. So there's a clear female preponderance. So if a disease onset is less than 2 years, monogenic form of autoinflammatory conditions such as Majeed syndrome or deficiency of interleukin IL-1 receptor. Like these are very rare things, DIRA and Majeed. So you only hear about these things in specific pediatric forums in autoinflammatory syndromes. So when they are very small, you have to consider these differential diagnosis. So clinical manifestations, we now know most of the clinical manifestations. The cardinal features of CNO is bone pain of insidious onset. Maybe they have swelling over the painful area, but I didn't see this in literature. But what I have felt is these can be dramatic swellings. I have seen patients presenting within 1 week of symptoms. And the thing that struck me is bony hardness of this lesion, the swelling. So I had one girl who is having dramatic swelling of her hand. When I touched it, I felt, I did not know that it was a CRMO, but I felt the body hardness of that swelling. I didn't see that in any literature, but I have felt several times examining these patients. They come with acute dramatic swelling with bony hard feeling underneath. So that is bone is actually rapidly expanding, quickly expanding at the very onset, I think. So there's focal tenderness with occasional movement. CNO may be recurrent, episodic. We saw this with the case illustrations, and or persistent. Some kids have persistent pain despite the NSAIDs. And it can involve only one area, or it could be unifocal or multifocal. So it may affect any bone, but there are areas that there's a high predilection to get these changes. So metaphysis of the long bones of lower extremities, the most common site scenes, but I have seen things happening in forearms, metatarsal, metacarpal bones, followed by pelvis, vertebra, clavicle. I'm yet to see a clavicle. I didn't see any clavicles getting affected. Long bones of the upper extremity and mandible. Mandible is also in the literature, they talk a lot of the involvement of mandible and the vertebrae. I have seen many vertebrae getting involved, multiple vertebrae, then it is really, really confusing. There was one girl who was coming with this collapse of one thoracic vertebra. Her mother was bringing her. It took years for me to, come to the solid conclusion that this may be CRMO. We tried to do biopsy with the orthopedic surgeon. We did not agree. We looked for COX. We looked for malignancies. At the end, the mother has been developing cancer, and she is neglecting herself to bring this child so many times to the hospital. And the mother eventually died. She has neglected and didn't go with her first symptoms. So it can be very difficult to diagnose these cases, especially when the vertebrae are involved. So associated conditions. So this can be really confusing. Now psoriasis can be affected, associated. There was a beautiful slide in one of the articles with circles. I couldn't get it. It was not PowerPoint friendly. So there are associations that they can overlap. Like one is psoriasis and palmoplantar pustulosis, acne, inflammatory bowel disease, and spondyloarthropathy. Our child had a very sacroiliitis, so there's an association with spondyloarthropathy as well, and enthesitis, ERA, that is related arthritis, so which can be misleading, right? So sweet syndrome, Takayasu, pyoderma gangrenosum, these are less common associations. So there are diagnostic criteria, but there are major criteria and then different criteria, Janssen and Bristol, but none of these criteria are solid. So we're still looking to formulate proper criteria. So if you take the major criteria in one of these, so radiologically proven osteolytic or sclerotic bone lesions, multifocal bone lesions, palmoplantar psoriasis or pustulosis or psoriasis, sterile bone biopsy with signs of inflammation, and with fibrosis and sclerosis. So, and minor criteria, you need more than 2 major criteria, or 1 major plus 3 minor criteria. Minor criteria for normal blood counts and good general state of health. So this is again controversial because our girls had, very high ESR and CRP in one state. So CRP and ESR mildly to moderately elevated. So this way or that way could be observation time longer than 6 months. I think that is very valid. And hyperostosis, and the literature says this can be associated with hyperostosis also. So in adults, it might present as hyperostosis. Dish lights in pictures. So this is grade 1 or 2 relatives with autoimmunity or autoinflammatory diseases with non-bacterial osteomyelitis. One of the people in the family has it. There might be other members also have it. So it's genetically related. So how to diagnose the initial evaluation? We have to always rule out infections, full blood count, CRP, ESR, and cultures to evaluate for infectious osteomyelitis and other major diagnosis like malignancies. So the majority have normal full blood count, CRP, and ESRs. Some present with significantly elevated, as we saw in the second case. So alkaline phosphatase is reduced in hypophosphatasia. Otherwise, it might be gone up. Right? Imaging, radiograph of all painful sites. Poor sensitivity, only 15% will have extra changes. But almost all the cases, this is what the literature says, but almost all the cases I saw had very dramatic, very early disease and very dramatic extra changes. Thus, MRI is the gold standard. They say the most valuable investigation. Even when the only the pain is there, there's no extra changes, can detect the bone edema. When even when the radiographs are normal, you have to go for an MRI. In addition, clinically symptomatic lesions, also known as silent lesions, you have to image. Vertebral silent lesions may lead to compression fracture. So I have many, not many, about 3 kids who got collapsed vertebra. That's whole body MRI is the gold standard. So typical findings of CNO, each type of imaging, radiographs, lytic lesions, sclerostic and cortical irregularity, and hyperostosis, and vertebral body height loss. These are the features that you are going to look at. MRI, including whole body MRI, increased intensity of stir signals within bone marrow, increased intensity of stir signals with surrounding tissues as well. So this MRI shows a collapsed vertebra body, and bone scan shows increased uptake, and PET scans also show increased activity. So biopsy of bone and other sites, infectious osteomyelitis and malignancy needs to be excluded, and a unifocal lesion other than the clavicle, even if it is a typical location, a bone biopsy is recommended, because otherwise we are going to miss things. Bone marrow and other lymph node biopsy to exclude leukemia or lymphoma. The secondary deposits can present like this. There's no distinct diagnostic feature in bone pathology for CNO. Common findings would include destruction of normal bone structures and presence of neutrophils, monocytes, lymphocytes, and plasma cells during early phases, or predominance of fibrosis and sparse immune cells during later phases. A mixture of fibrosis and inflammation as well as normal bone is also often reported. So the biopsy is has very non-specific features in CRNO, but we need to do a biopsy to exclude other things. So how to treat this patient? It's the next question. Because the world literature they are trying a lot of treatment for this, but sometimes they don't prove to be effective. But initial therapy is daily NSAIDs at standard doses. So some of these kids, they just settle with the NSAIDs, and then there are long prison periods and we can even withdraw the NSAIDs. After 50% of patients achieve clinical remission within the first year, starting in an NSAID, but relapses are common and new lesions may develop. Sometimes they come with another site, pain in another site. But most clinicians trial patients of NSAID if there are no clinical symptoms and MRI shows no or minimal disease activity. Now we do repeated MRIs in these children. If everything seems silent, we can just withdraw and see. Children with episodic flares may only require treatment with NSAIDs for a few months, and then we can go withdraw and see how it goes. So, but you can never let go of these kids. You have to follow them up. So, additional treatment options. So, frequent, if the kids get frequent flares despite NSAIDs for 4 to 6 weeks, and active spinal lesions or heavy burden of disease with significant physical limitations, those who have persistently active symptoms, like second child who has had bone expansion, silent disease maybe, but bones have been expanding all the time. So these children need further treatment. Our abdominal MRI findings despite 4 to 6 week trials. So the options are tumor necrosis factor, TNF inhibitors, TNF, they have tried infliximab and Belimumab, and there are a lot of research on IL-1 receptors, anakinra, but there are instances that they have failed even anakinra, they have failed one type, they are switching for another because it's not the pathophysiology or the immune reactions involved are not really fully understood. So then if you fail or you have no good response, you can switch between the classes and then try bisphosphonates. Or even oral disease-modifying drugs. So these drugs are necessary to induce remission and reduce skeletal damage. So we need to find some way or the other, one agent or the other, to keep the disease at bay, to prevent the bone getting affected and they can even get pathological fractures, because as you can see, the bone can be very brittle and weak. So disease activity monitoring includes regular imaging. So you have to, you can't go by ESR, you can go by CRP. You will have to repeatedly image these children, and regular imaging, preferably MRI, of discrete lesions, particularly symptomatic ones, and full examination by a pediatric rheumatologist in order to, for that matter, be a treating clinician to determine treatment options and duration. So there's no clear-cut, guideline laid down to treat these children, but you have to always closely follow them up. Each individual treatment should be tailor-made to that particular child, supporting care such as appropriate physical and occupational therapy, maybe orthotic devices to help. So the diagnosis and treatment may prevent or decrease complications of the disease. Prognosis is variable from mild intermittent episodes to an unrelenting cause with uncontrolled inflammation causing significant morbidity. Be there, unfortunate, I'm yet to see such a patient. All the current patients are present. Bone deformities can occur, fractures, growth failure, arthritis, neurological symptoms, particularly from some spinal involvement. That's the most dreaded thing, because the vertebrae can collapse and then spinal injuries can occur. Refractory and persistent pain syndromes. And psychosocial dysfunction resulting in poor quality, because the kids who are doing sports may be not doing it anymore. So a lot of impact. In summary, CRMO or CNO is a rare idiopathic autoinflammatory bone disease that is mostly affects children and adolescents. So you may also encounter one day. So differential diagnosis of CRMO is challenging and it is based on exclusions, can be misdiagnosed or mistreated. Early diagnosis and treatment may prevent or decrease complications of the disease. Treatment guidelines for CRMO is yet to come, still under discussion. But these drugs are necessary to induce remission. You can't wait till such time and to reduce skeletal damage. So I join hands with our orthopedic surgeon and we as a team manage these kids because we can't wait till the guidelines come. So I still cannot say one treatment is better than the other trials. So I should acknowledge Dr. Charmi Jayasinghe and Dilanka, who I discuss these cases very often, and Dr. Rajika. If not for her, I couldn't have done this presentation today with all my commitments. So, and the patients and parents in these case studies are also. Thank you.
Thank you. Again, for the presentation of something we think about. Any questions?
Can you place some steroids
In literature, they don't, advocate that, but people try antibiotics also. Antibiotics and steroids are also tried on these kids, but literature doesn't support that very much.
You said the MRI is the gold standard, but the MRI is very non-specific.
Yeah, but that remains a gold standard because you can do the whole body MRI, and if there are multiple sites and the specific sites that more frequently affecting, so it remains the gold standard. Even we do it for our kids also. The first thing they do is we go for a whole body MRI, and the literature also says the same. Because if you do a biopsy, that's an exclusion. For this, you can't diagnose it with the biopsy because it's non-specific.
Probably, but you can see that there is multiple sites in all and there can be localized.
Yeah. If you see a second or third site, it's most probably this.
And about the ANA positive,
I really don't know because it could be a distract. So people got distracted with it, and then lot of actually that Singaporean clinic note. It's very confusing. When you read about it, they talk about everything. There's no firm that is the same confusion was running down until Dr. Sunil said, Swami, this is CRM or nothing else. So the visual, recognition, the spot diagnosis, maybe the experience, sharing experience is what is the most valid. Because Palit and myself, we were also equally confused. There was this nurse's daughter coming up and down with very high USRs, vertebral lesions now, pain this month, no pain next month, and going quiescent for 6 months and then coming up again. So we were equally confused. So it's very confusing unless you have seen many cases. So that's why I thought it's worth sharing.
yeah, certainly, I think probably there may be some community connection.
Yes.
The JIE like presentation.
Actually categorized now as an autoinflammatory condition, and there are a lot of studies in NLRP3 gene connection and so on. So much of high stuff going on. It is an autoinflammatory condition.
Another question?
Pediatric cerebral, and all of your patients, is it only one side they have the osteomyelitis picture?
No, they have multiple sides. This girl with the forearm, but it's only one side. But there are other. I think most of the others have at least two sides. Multiple vertebrae.
I also can remember I've seen one patient like that. That patient also has been seen in Singapore, and then they have started on adult one. It's not the same patient. I have seen one.
Yeah, this one was suggested to give Goli. They have refused and come back, but it's not a bad suggestion.
And that patient is at that time it was not available. They were continuing adult one. It's a similar presentation.
Yeah.
Thank you, everyone. Just before starting our next, and this will be done by the Registrar Rehabilitation Medicine on a medical problem. Ultimately, need a lot of rehabilitation. What do you do?
Good afternoon, everybody, and thank you, sir, for the those kind words of introduction. So, for the next 20 minutes or so, I'm discussing about central pontine myelinolysis based on 2 case histories that we had in our rehabilitation hospital. So, my content presentation will include start with case histories, and then I will discuss a few facts on medical diagnosis and management, and I will analyze detailed rehabilitation management, focus on one case history, and I will analyze the examples based on the ICF bundle, and I will discuss the rehabilitation management. Finally, I will conclude with few take messages. The case history 1 is a 38-year-old mother of 2, present previously on-screen patients, admitted to local hospital. December last year, due to some acute onset oxidative persistent vomiting and an episode of fainting attack. At the local hospital, she was managed with intravenous fluids, and due to deteriorating liver consciousness, patient was transferred to nearest teaching hospital. And at the tertiary care center, patient had features of spastic quadriparesis and received ICU care in 2 weeks with ventilator support. An available initial sodium value was 140. On evaluation at the tertiary care center, CT revealed mild cerebral edema and EEG showed intermittent airway slowing and no focal changes. Subsequently, a patient was sent to medical ward with the diagnosis of brainstem stroke after seeing the consultant neurologist. And on discharge from ICU, the GCS was 8 tracheostomy. And then subsequent patient was retransferred to local hospital and has continued care with 23 days of stay, and then discharged home with care advice given to the hospital. However, following day, patient was readmitted to medical casualty of the National Hospital by the hospital in the hope of seeing further care. So on admission to NHSL, patient's condition was GCS 9 by 15 and on tracheostomy, and patient was quadriplegic. The MRI film taken on at the National Hospital revealed high intensity area in the center of bones with diffusion restriction with all infarctions left cerebral. So MRA, MRV, and Efficacy are normal. And then retrospective diagnosis of central pontine myelinosis is made. Patient has undergone 5 cycles of, and the subsequent patient was transferred to rehabilitation hospital for long-term rehabilitation care. This is the MRI patient. This is 2. This is a 59-year-old female was admitted to a private hospital due to a subacute onset behavioral disturbance, mainly insomnia and vomiting progressing in 2 weeks. And patient was actually seen by psychiatrist and has prescribed some drugs. And in the background history of she was a diabetic, hypertensive, administered dyslipidemia with hypothyroidism, upper follow-up. So on admission, patient was conscious and rational but drowsy. Basic investigation revealed upon hyponatremia, and on admission MRI is normal, and then patient was managed in the ward with intravenous fluids, and 24 hours later the sodium level was 126 millimoles per liter, and then patient's condition level of consciousness deteriorated and then transferred to ICU, necessitating ventilator support. So, subsequent MRI taken showed high intense signals in the dorsal forms, bilateral body nuclei, internal and external capsules, and thalamus with mildly heterogeneous signals changes in central pontine. And the features are in keeping with extra pontine and central pontine myelinolysis. Again, patient was managed with 7 cycles of TPE, then subsequently transferred to rehabilitation hospital. So with these two cases in mind, let me discuss the effects on this deadly diagnosis. So it was initially described in 1958 by Adam Sinclair based on his observations in patients with alcoholics and malnutrition who developed paralysis and pseudobulbar palsy and very indicative of encephalopathy. And it's a non-inflammatory demyelination within the central venous context. And in 10% of cases with central pontine myelinosis, extrapontine involvement is also seen, mainly in midbrain, thalamus, based on nutrient cerebellum. Therefore, the osmotic demyelination syndrome is the most appropriate term and is the first term used at this condition. So the pathophysiology, what the proposed theory is, it is due to the compact integrated the brain that in its compact integrating fibers due to cellular edema caused by this fluctuating osmotic forces to cause compression of the fiber tracts, inducing demyelination. So there are several non-predisposing factors like alcoholism, liver disease, malnutrition, and hyponatremia. So the risk factors for osmotic demyelination syndrome in hyponatremia: serum sodium level of less than 120 milligrams per liter for more than 48 hours, and the aggressive IV fluid therapy with hypertonic steroid solutions, and development of hyponatremia in the treatment. These are the risk factors for osmotic demyelination syndrome in hyponatremia. So the typical history is the patient will be admitted with acute delirium, side disturbance, and patient is being managed with IV fluids. And following day, they will have normal sodium. And initially, patient's alertness will be improved, but then to deteriorate in next 48 to 72 hours. That's what is happening in our two patients. The clinical features, they present with confusion, osmotic acidosis, and spastic quadriplegia due to the involvement of the corticospinal tracts, and also the pseudobulbar palsy and head and neck weakness and dysphagia, tachycardia and emotion damage in the corticobulbar tracts involvement. In advanced stages, we have features of Lopton syndrome due to paralysis of lower cranial nerves in musculation, intact vertical eye movements, and blinking and respiration. The radiological diagnosis, the MRI finding is that this hypointense T1 lesion, which gives this characteristic trident shape in the MRI, which is characteristic of this condition. This is the T2 flare, where it is high intense signal outlining in the trident pattern, as you can see in the image. So a little bit on hyponatremia. So the basic stuff is defined as serum sodium less than 135 milligrams per liter and can be mild, moderate, and profound. It's profound when it's less than 125 millimolar per liter. And further, in point of the management point of view, what is important is volume-based classification where it can be hypervolemic hyponatremia, volemic, or hypervolemic. And also there's a tonicity-based classification. So in the management, the acute hyponatremia, directly caused from landscape. So the treatment of symptomatic patients with acute hyponatremia, that is, which is occurring less than 20 to 48 hours, urgent correction is recommended by 4 to 6 millimole per liter to prevent pain herniation and neurological damage or cerebral ischemia, ischemia. And in severe symptomatic patients, 100 ml of hypertonic saline infusion for 10 minutes, and you can repeat it 3 times if needed. But in mild to moderate symptoms and patients have lower risk of pain herniation, you have to go with more slower rate of hypertonic saline infusion at 0.5 to 2 ml kg per hour. So in chronic hyponatremia, the long duration is more than 48 hours. We have to be careful and we can go for minimum correction of sodium by 4 to 8 millimole per day. Lower goal of 4 to 6 millimole per day if the patient is at high risk of osmotic dehydration syndrome. And in patients with normal risk of osmotic dehydration syndrome, you can go for maximum correction of 10 to 12 millimole per day in the first 24 hours and maximum of 18 millimoles in the 48-hour period. So I will discuss in detail about the case in the patient and that I mentioned in case 61. So she's a 38-year-old mother of 2. On admission to rehabilitation hospital, she had stable vitals and GCS is 9 by 15, and she was unable to speak but can understand, and she was quadriplegic, non-gastroscopy, and urinary catheter and bowel incontinent. So it's based on ICF model, which stands for International Classification of Function, Disability and Health. It is the WHO framework of assisting a patient's functioning and disability. It is the international standards. So it has 5 components. It has body health condition, affecting body functions and structure, causing activity limitation and participation restriction, and it is also affected by contextual factors, mainly environmental factors and personal factors. So, with regard to our patient, on admission, patient was quadriplegic, body functions and structures are affected. Our patient was quadriplegic and she had impaired autonomic functions, mainly better bowel and sexual functions, and she had impaired swallowing and voice functions and impaired mental functions, and she has spasticity. The activity limitations, all areas were dependent, and she has restricted mobility, and she has significant restriction in communication. Participation restriction, all her domestic life is affected, and interpersonal relationships, family relationships, and intimate relationships, and community life is all restricted. The environmental factors, the strong facilitator for this condition, the good mediator and extended family support she had, and definitely she had financial difficulties. The personal factors, the positive personal factor is she was younger female, young age group, which has a positive impact in the management. However, she was depressed and she has emotional ability, which are negative factors. So the initial multidisciplinary treatment actually after the specific review, our focus is on to establish initial team goals and to emphasize on interdisciplinary roles, and also to incorporate the patient in the family collaboration to have a comprehensive care plan. So the initial treatment goals, broad treatment goals, was to manage bone management. Also, management patient had significant upper limb spasticity involving rehabilitation, and also to improve the active tolerance. Because patient was bedbound for a long time, so in order to have active participation in therapy, had to improve the active tolerance of the patient, and also to improve the access to the environment. The patient was bedbound, and we have to mobilize the patient out of the bed, improve access to the environment, and then gradually introduce functional training. In this broad treatment goals, in each section, there were short-term goals in the each discipline, and they were reviewed in weekly multidisciplinary team discussions. And with that, we made a stepwise functional improvement of the patient. So, when it comes to spasticity management, for those who are new to this term, it's a motor disorder characterized by spasticity is a motor disorder characterized by velocity dependent increase in chronic stretch reflex. It exaggerated tendon jerks resulting from excitability of the stretch reflex as one component of the upper motor neuron syndrome. This is the very initial definition given by the Lance in 1980. However, there's another definition given by Pandey in 2005. He describes this as a disordered sensory motor control resulting from an upper motor neuron lesion as an intermittent or sustained involuntary activation of the muscles. So, for a patient, so actually the modified Asher scale is the clinical tool that we are using to assess the spasticity. So it assesses the static component of spasticity. It has 4 grades. As you can see, 0 is there's no increase in muscle tone, and 1 is there's slight increase in muscle tone manifested by a catch and then release or by minimal resistance at the end of the range of motion. Grade 1 plus is slight increase in muscle tone manifested by catch followed by minimal resistance throughout the remainder of the range of motion. And grade 2 is more marked increase in muscle tone through most of the range of motion, but the affected limb can be moved. And grade 3 is there's considerable increase in muscle tone and the passive movement is difficult. And grade 4 is affected part is rigid flexional stage. So when it comes to our patient, she has significant spasticity going upperly. They are at the wrist, right wrist position with involvement of the flexor carpi alveolis and the flexor carpi alveolis. The Asher scale from grade 2, and she had bilateral clenched fist with thumb and palm deformity. The involved muscle groups are the flexor scoliosis and the bilateral flexor pulse longus. And Asher scale was around grade 3. And we managed physical therapy, sprinting, positioning, and also we gave a botulinum toxin in the context of multidisciplinary setting, achieving functional goals, holistic functional goals, improving hand extremity. So, and when it comes to functional improvements, functional mobility improvement, she achieved independent mobility, bed mobility by 4 weeks, and blind sitting with mild assistance by 6 weeks, and independent static sitting with 6 weeks, and also in sit to stand with moderate assistance in 8 weeks time, and was able to stand in between parallel bars 12 weeks. So when it comes to activities of daily living, for 10 weeks she was independent in feeding with adapted spoon and independent, she achieved independent moving in 10 weeks, and she was independent in upper half dressing in shorts by 12 weeks. So she had significant impairments in speech and swallowing. So on addition, swallowing is impaired and has impaired voice, impaired verbal expression. So however, it gone rehab, she achieved normal swallowing by 10 weeks, and on addition, she was aphoning, but she initiated phonation by 12 weeks, and however, it was inconsistent, and then had to introduce an alternative communication method, and with that, now she is communicating. So she has significant mental disturbances, has moderate depression with emotionalism, and so we have done psychological assessment and we not manage with the help of the psychiatry, the kind of pharmacological treatment. So the bladder functions actually we tried to use on catheter, we have tried the catheter, but failed times. We plan to keep it for a long time until the upper limb kind of functions are improved so that we can manage it. So this is a few images that I have taken with the consent of the patient and the family. So she achieved the independent sitting after 12 weeks of inward rehab, an independent feeding, and also and the patient is able to stand within the tunnel bars. So this is after nearly 3 months of staying in the rehabilitation hospital. So this is a really a difficult task, as you can obviously see. So therefore, and this is the outcome assessment during your rehabilitation. So as you can see on admission, the bathroom index was 0. So at 8 weeks, it improved to 25%, and at 12 weeks, it improved 30%. And the functional independence measure, the film, the most subtotal on admission was 13, and at 8 weeks, it improved 20, and 12 weeks, improved 33. Cognitive subtotal was 30 marks. Addition 24 in 8 weeks and 24 in remained 24 by 12 weeks. As you can see, there has been stepwise improvement during the stay at the rehabilitation hospital, but this improvement is not in keeping with the patient and the family expectation. So, and the contributing factors may be multiple, the severity of the initial brain injury, also the delay in initiation of over